I got a few emails last time. In fact, at the very end of the class, a couple of your colleagues did bring up the idea that the central incisors are really the most important tooth in the head. And yes, I did say that, but I do want to clarify what I really meant by that. The traditional paradigm in dentistry has been that function always comes first. If you are believers of that dogma, then I would admit that the canines would probably be considered superior. I happen to come from the viewpoint that actually aesthetics trumps everything else, with function being a close second. So when I talked about the position of the central incisor being critical and being the most important, I did not mean it at the cost of canine guidance or, disclusion. I did not mean that, so I just wanted to clarify that because I did get a couple of emails besides the two colleagues of yours who brought it up. Is that kind of clear then? Which I think was the example I used. You set the central incisor, but you don't compromise on canine guidance. And that's essentially what I was getting at. There was another question or another comment that I got that I want to clarify. Somebody mentioned that the use of a headgear can effectively replace the need for surgical repositioning of the maxilla. Now that's a very strong statement to make, so I just wanted to clarify that. A headgear can be very effective in controlling the position of the maxilla when a person is still growing. Surgery is usually reserved for people who are non-growing. So there are two different populations that we're talking about. Any questions about those two? Bless you. There was one more comment I got, and I remember I responded to it, and then I got a couple of questions back, and I said, maybe I'll clarify this in class, and unfortunately I don't remember the question. But if that person's here, can you please remind me? Alright, so the person's not here, it makes it easier.
Which person?
I don't remember. It was, I got a response that night, and I responded saying, I gave them an answer, and that triggered another question, so I just said, maybe we'll discuss this in class. I'll have to pull up my emails, but...
Do it. We got a little time.
And maybe I'll do that in the next class, because I do have one more session with you. Okay, so today we're going to take up mandibular growth, and very similar to the way I try to go about maxillary growth, I'm going to try and look at the two things that are important here. One is the biological basis for mandibular growth. How does the mandible actually grow? And again, second, I'm going to try and look at some of the clinical relevance of what we're talking about. Now this might be a slide that you're all familiar with, but I think I'm really going to be focusing on this particular component of the craniofacial skeleton. And as I talked about in the first segment, the nasomaxillary complex is pretty much suspended off of the anterior cranial base. The middle cranial fossa has some effect on the position of it, but the mandible is actually probably, as you probably saw even in the videos from Dr. Mark Hans, one of the most complex, interesting bones of this craniofacial skeleton. And it's anchored actually at the rear end or the posterior end of the middle cranial fossa in the temporal bone. There are different components of the mandible, and for the sake of simplicity, I'm going to try and break that down into the four components that you see here, and a fifth one which would really be the coronoid process. So let's take the condyle, and I'm going to come back to it. How does the mandible form? Unlike the maxilla, which is formed primarily by what? What mechanism is it? Is it intramembranous? No, I'm talking about the maxilla.
Oh, mass.
It is primarily intramembranous. There's no real cartilage there. Here, on the other hand, you do have a center which actually actively is growing through endochondral formation, because the condyle is all avascular cartilage. Now when I say all, I'm really talking about a medullary segment there, and that's why I'll get back to that. So that's a really, really important part of the mandible. There are muscle attachments, ligaments attached to it. And perhaps the most important characteristic of it is that it allows for motion, which is what allows us to chew, masticate, swallow, a host of different activities that are critical to survival. The coronoid process that you see here is a major part in terms of attachments. Which muscle attaches there? It's a major muscle, the temporalis. So that becomes a very critical part of the mandible as well. You can then look at the rametal segment, and again, there are different parts of this that are growing at different rates. But the ramus is critical in actually connecting this segment, the condyle, to the corpus, which actually contains in it the alveolar process. So the ramus actually determines, in some ways, the position of the corpus, which in turn can influence the position of the alveolar segments. And it's capable of great adaptation, which allows for teeth to fit together. Let's take a look at it. Here's the middle cranial fossa. You have the sphenoid-occipital synchondrosis in this area, part of the basic cranium. You're all familiar with this, correct? Okay. And you can see where the condyle is actually attached to the glenoid fossa there. And the idea is that the middle cranial fossa is actually approximately the same width as the pharynx. And what you find is these arrows represent what happens with the middle cranial fossa, with this surface being more depository in nature and the internal surface of the endosteal of it actually being resorptory in nature, which means this is getting displaced downward and forward. Very similar to the maxilla, the direction of displacement of the mandible is downward and forward. So you can see over time what happens to the position of the mandible.
What did you say about the middle cranial fossa is what with the pharynx? About the middle cranial fossa? No, that's not important.
I'm sorry? Yeah, it actually, in some ways, is about the same width in terms of your pharynx.
Oh, okay.
Yeah. And as you can tell, there is an AP dimension to this in terms of anterior-posterior, where there's a downward and forward displacement. There is also a vertical component to it. Here you can see that actually as the displacement is taking place, there's going to be a vertical change that takes place as a result of the dental drift that takes place, and alveolar height increases. Again, very similar in some ways to what we talked about in the maxilla. The difference being the dental drift took place in an inferior direction, and here it takes place in a superior direction as you establish the plane of occlusion. In other words, the lower dentition migrates superiorly. I'm sure you remember we talked a fair bit about the maxillary tuberosity. And very similar to the maxillary tuberosity, there is a lingual tuberosity in the mandible. That lingual tuberosity is typically found at the junction on the lingual side of the corpus and the ramus. And that also is an important aspect of it because that is depository in nature. Any questions up to this point? Let's take a look at the actual ramus as we were talking about it, and let's see what happens to the ramus. On the posterior aspect of the ramus, you actually are having deposition take place. And the anterior border of the ramus actually gradually tends to migrate posteriorly as that becomes resorptive in nature. Very much like we talked about in the case of the maxillary tuberosity, this method and this mechanism by which there is a relocation that takes place of the actual ramus creates additional space for which teeth? Your molars. And we'll get back to the conversation we had about wisdom teeth, because it's not very different when it comes to the mandible. You can see the condylar proliferation is actually taking place in a posterior superior direction, very similar to the choroid process. And while a lot of the growth is taking place in this area, which tends to be called a growth site, the truth is there are changes taking place all along. And again, I'm going to try and get you to think about it in different planes. The anterior-posterior vector, certainly in the vertical dimension, and from side to side. Now when I say side to side, that's not really represented here, as you can imagine. But the bicondylar width, or the position of your condyles, although there are modest changes that take place over time, typically by the age of about 4 or 5, the bicondylar width is pretty much established. Why is that? It's because the width of the basic cranium is fairly well established. So you don't see a whole lot of changes taking place beyond that age in the transverse plane, in the side-to-side position. You will find, however, that with the ramus, there is deposition that is taking place on the lingual aspect or on the medial aspect. Away from the buccal surfaces, you do find deposition taking place on the medial surfaces, which actually makes the ramus come closer and closer into alignment with the corpus of the mandible. Remember, the ramus is typically more lateral to the corpus. And here's just a schematic demonstrating what happens, and I think we have a better slide here. And all this is very well referenced in your text. I'm essentially going over some of the highlights. There are 4 different zones in the medullary area of the condyle. And I think there's a very apt description in your book that talks about it being like a corkscrew in a wine bottle. Because this essentially is your endochondral site. Now there are different layers in it, as you can see here. Layer A, which is the most avascular, more of a capsular layer, which is actually in contact and therefore undergoes some compressive forces. You have layer B just under that, which is your pre-chondroblastic layer, and you can see that it's densely packed with pre-chondroblasts. Then you have the actual chondroblast layer, and lastly you have your endochondral layer, and that's how this grows outward. The cortical areas that you're actually looking at here form more by intramembranous bone formation, and that's where your attachments are, your muscular attachments.
What do you call the first layer?
A capsular layer?
Oh.
Essentially it's an avascular area.
What was the last one again?
That's the zone where you actually have bone. So that's your actual endochondral bone. And so I think I already went over this, how things, as they remodel, they get reallocated. And I think the ramus is actually a great example of how the anterior border can actually be resorptive in nature. You have a depository nature taking place on the posterior border of the ramus, and gradually over time, the corpus actually lengthens as the ramus gets remodeled and relocated. And somebody just mentioned to me that I need to put these up on Blackboard, which I'll do. So. So this is how you have the infant, if you will, mandible actually remodel over time and actually become more of an adult-sized mandible, with the anterior border being resorptive, and you have a posterior border that is a depository in nature, a lot of condylar activity in the posterior superior direction. I think we can also notice that there's a lot of vertical changes that take place as a result of the dental drift. Any questions about what we just talked about? Remember how we talked about this particular area? Well, I want you to assume or think of a person who doesn't have a condyle. What happens to them? Would you expect the rest of the remodeling to take place the way it does? So let's take a look at it. Here's a child, and again, when you're looking at a panoramic radiograph, this being the right side, that being the left, you can see that there is a condyle here. Granted, it's not the greatest view, but do you see a condyle on the opposite side? So this person, where you can see this, some permanent dentition, some primary dentition, is born without a condyle. And as you would expect, you will see a fairly dysmorphic mandible. Yet the incredible part is, while the teeth don't exactly fit together the way you want them to, I'll grant you that, the person still has the ability to masticate. And this goes back to the ability to compensate for things, where you can have ramal angles and you can have dentition that will actually compensate for various components being off. And I know that you have an entire session on how these compensations take place. Have they already touched on it in some way, shape, or form? Okay, because there's a whole session on the compensations that occur and how the dentition, meaning also the alveolar segments, how they compensate for the position of the actual basal bones. So you see in a situation like this, how that compensation can occur. So clearly, the lack of a condyle means, just imagine in this own room, the condyle missing, everything is going to drift to that side, the entire mandibular complex. But simultaneously, that means that there will be an increase in this dimension, because you're missing something here, everything drops down. And you can see what happens to the dentition. Everything is drifted off to one side, and there are significant compensations.
Can an oral surgeon do anything about that, or can we make it?
Yes, I mean, all these, we do treat them. They're all treatable cases. Different ways of treating it. In this particular case, you'd have to build a condyle first. So you would actually harvest part of the rib and build a costochondral graft before you can do other procedures to actually correct for the dysmorphia.
Was part of that compensation include missing a permanent dentition?
That's a very good question. The question was, can part of the compensation be that they're missing teeth? Now, many of these conditions, they will present with missing teeth. Whether or not there is a cause and effect has never been demonstrated for this particular condition. There are other conditions in which we know that missing teeth are part of the genetic spectrum. But in this particular case, if the child is missing a tooth, we would not be able to attribute it to a compensatory mechanism. Now, this was a condition where the person is completely missing one condyle. What about in the case of a young lady or a young individual who's undergoing an autoimmune disease called juvenile rheumatoid arthritis? Let's take a look at their condyles. This is the condyle on the left. These are the condyles on the right. And these are just different images I've taken off of the CT, the cone beam CT. And what happens in this is there is degeneration that takes place of that capsular layer, and it starts going through the condyle. So what happens in a case like this? And this is not necessarily a child, it's just early juvenile rheumatoid arthritis. In fact, if I'm not mistaken, she was 19 years old when she came to me. What would happen if the condyles gradually started resorbing? Whatever stump is left is still going to try to be seated in the fossa. So what's going to happen over time?
It's going to move back.
It's going to keep moving back. Now you mentioned the AP plane of space. What's going to happen in the vertical dimension?
Superior. Move up.
Why would you say it will go superior?
Just a lack of condyle, which is vertical. That's vertical.
So if you took away the condyles, why would you expect it to rotate counterclockwise?
I wouldn't, what do you mean counterclockwise? Counterclockwise.
Would you expect it to drop down? I'm talking just in the vertical plane. Would you expect it to drop down, or would you expect it to actually, the chin to project further forward?
Drop down.
To drop down.
Yeah.
So now you've identified how it affects things in two planes of space. There were two questions earlier. Or two people I thought raised their hands, no? And that's exactly what she had in this particular instance, where she came in with a mandible that had dropped down, causing a big open bite. And also in the AP plane, the mandible had become more deficient. If you wait long enough, there probably can be some dental compensations that will occur over time. On her, we probably caught it early enough. There were not a whole lot of dental compensations that occurred, but this is where she was at. Again, an instance where that growth balance has been disrupted. So what you do in a case like that is you, again, solicit the help of your craniofacial surgeon, and you go ahead and you correct for the problem, and this is where she finished up. Let's take a look at the alveolus for a second. Remember how we talked about, at least I think I mentioned, what happens when a tooth is missing? What happens to that alveolar segment?
Drift. Just drift.
Sorry?
Drift.
Drift occurs when as teeth are erupting, right? So they tend to erupt towards the occlusal plane. So they're moving in a vertical direction. They tend to move mesially. They tend to move laterally. I'm talking about an instance where you have a tooth that is actually missing. What happens to the tooth-bearing bone that we call alveolar bone? It resorbs. It undergoes disuse atrophy. So very much like an erupting tooth will bring with it the alveolar bone. The minute the tooth is lost, alveolar bone is lost. When I say the minute, I don't mean it literally. It's a, meant that more figuratively. But what I'm trying to get at is that if you're missing teeth, you will lose bone. And when you're setting a denture, I keep going back to prosthodontics, you will find that you will place teeth in acrylic. That acrylic that you're building up is essentially replacing the lost alveolar bone. So on a kid like this who I see, who is missing, if I'm not mistaken, I think, well, you'll see in a second, he's missing several teeth in the anteriors. Fortunately for him, he's got some posterior teeth. Granted, some of them are primary teeth, but at least he's got some teeth. You have loss of the alveolar ridge. And so I think this highlights, this kind of a condition highlights the importance of the dentition in terms of even establishing the vertical pattern of the face, or the vertical dimension of the face. Because if you're missing teeth, the lower anterior facial height and the distance between your nose and the chin point completely collapses. Any questions about that? Can anybody guess what condition this is? Maybe from your undergrad days? It's actually a condition called ectodermal dysplasia, where a person is born with 15, 16 missing teeth. Sometimes they're born with even more missing. We have one upstairs where they have only 4 permanent teeth. All the other teeth are missing. So it's a pretty intense case. Let's take a look at the length of the corpus. Now, we talked about how the length of the corpus is formed by resorption of the anterior bar of the ramus, deposition taking place in the posterior, which results over time in the lengthening of the corpus of the mandible. What are the functional issues that you can deal with on a child born like this? Where there is actually a condyle, there is a ramus, there is a corpus, they're just not in balance. So what happens when you have a short ramus, a short corpus, to a baby? The tongue includes the airway. And if a child is born with a tongue that potentially can include the airway, you'll see both sides.
So that's, this is just, does that affect, is it pulling his ear? Because his ear looks just,
Yeah, that's actually part of the syndrome that the child had.
So it just, that's what it is, it's not it's pulling it forward or anything?
No.
How does it work, that was a pretty drastic move with the skin.
Yeah, at that point, when the child is unable to ventilate on their own, you just do whatever you have to do to get them to be able to breathe.
Yeah.
So, but yeah, that's really a result of a dysmorphic mandible.
What happens as the child grows? Will you have to intervene later?
It depends on the actual clinical condition, so it depends on the syndrome you're dealing with. Oftentimes you will have to go back in and redo things. On certain conditions, there are sequences like pure advanced sequence where typically the child will tend to grow back into a normal position. But there are other conditions where the mandibular retronathia is static and you actually have to help it along as the child grows. The ramus, I think we already talked about it. One thing that I did not mention is the junction between the actual, the ramus and the corpus, which you can actually feel on yourselves, the antegonial notch that typically is representative of that junctional area. That's also the area on the medial where you'll find that lingual tuberosity that I talked about, which is actually depository in nature, both in the medial aspect as well as going posteriorly. That deposition that takes place in the lingual tuberosity, in fact, is what helps lengthen the corpus, because when you think of the ramus, everybody just thinks of the anterior border, but it does extend onto the medial aspect. So there is a third dimension there. And then there's, of course, the chin. And functionally, that might have a smaller role to play than some of the other important things I showed you, although you have to remember that a lot of the suprahyoid muscles are actually attached to this, and that can affect the position of the hyoid bone, and that then, in turn, may influence the airway. But essentially, when you think of the chin, the superior part of the chin is actually resorptory in nature. And this part here becomes depository in nature. A slide that I think will show this better is what you're seeing here. So you can see that the external surface is resorptory in nature, while the internal border is more depository in nature. And this on the lingual side, you can see is depository in nature. This becomes a little more critical when you're talking about, especially for males, because males tend to remodel for longer than females do, and I put in a case just to illustrate my point there. Here's a kid that I treated a while ago. And he has some obvious crowding, too many teeth. And if you take a look at him, he's fairly long in this dimension, but otherwise his teeth come together. It's just a normal teenager. And so we decide to go ahead and treat him. We extract some teeth. We get things to fit together better. And this was a case I pulled up intentionally because I'll show you what I did. So there was a little bit there's too much crowding in this area, so we take out some teeth, we get the teeth to fit together, we correct his claustrum malocclusion, and this is where I finish him up. And for the critical eye, you're going to say that this is still a fairly convex profile. And I will admit that it is, but the beauty of what we do is you and I are the only ones who can actually visualize the outcome. When a patient sits down in the chair, you're essentially the only person in that room who can really, in your mind's eye, picture what the final result is going to look like 10 years later. And so here's the guy at, I think it was 14, 15, and this was where we finished him at that time. Fairly good orthodontic result. But when I take a look at him here, I admit that his nose is flat, his chin is down. But as you would know from the last class and from today, over time what's going to happen? Both are going to change. And so he's now actually in med school right here at Case. And this is him when I saw him last. So I think you can see what happens over time. Just natural growth, natural remodeling, natural displacement of things, what happens. Whether it is with the chin point, which is really the point I wanted to make here, I think you can see there's much better definition to the chin point in this particular case. Any questions about the segments that we just talked about?
I thought you said the lingual side of the chin was like depository, but it looked like his chin came...
Actually, when I'm talking about the lingual side, I'm really talking about the internal cortex, so what you would feel with your tongue.
Right, but on his it looked like the chin, I don't understand if it's, so it's like shifting anterior, but it's depositing on the lingual. Is that what you're trying to get at?
Yeah,
Okay.
and you're having some resorption on the superior surface, so there's greater remodeling at the base of the chin.
Okay.
And again, I'm going to come back to your favorite topic of wisdom teeth. On this particular panoramic radiograph, which again, I don't think is the most diagnostic for these, you're going to look at these and say that the wisdom teeth are impacted. And you can certainly, you're welcome to make that assumption. The issues that you have with this is, remember, it's a two-dimensional image. And based on what we just talked about, these third molars are essentially at the junction of the ramus and the corpus. Now, what's the path of eruption of the third molar? It erupts lingual to the ramus, correct? Closer to the tongue. And that surface where you have the lingual tuberosity is what? Is it depository? Yes, it is. The anterior border of the ramus is actually resorbing. So you have resorption taking place here, you have the ramus relocating backwards, you have deposition taking place right there. So it may be premature to make that call on a child who is still, or a teenager who is still growing. And that's why we typically will tend to wait, because if you take a panoramic radiograph, the anterior border of the ramus will oftentimes superimpose, and so it will look like there is an impaction, when in reality, you may have a lot of time left in terms of what's going to happen to that position of the ramus. You can also see how the third molar is erupting lingually, lingual to the ramus, and that makes it quite difficult to categorize something as impacted at that age. You're much better off waiting a little while and making sure that it truly is impacted, which in this case you can see they seem to be erupting fine. And that's not to say that true impactions should be ignored. Because here's a case of a true impaction, where something was impacted, it was ignored, and guess what it turns into? It turns into a cyst. Approaching all the way the sigmoid notch on one side, and you can see where there's a massive cyst on the other side. So if you're dealing with a true impaction, don't hesitate to pull the trigger and get them out of there. Go ahead.
I was just wondering what's the approximate age range that it's okay to make the assumption or you should wait?
So I think I mentioned about that analytic study group that was formed last time, where they came up with the conclusion that you should not be making decisions on true impactions till the age of about 20. Having said that, if you see something blatant around the age of 17 or 18, I wouldn't hesitate. But I probably would not take them out just indiscriminately based on panorex at the age of 15 or 16, which sometimes does tend to happen.
So, but there's lots of, I guess, bad effects from leaving them in, like in terms of like cleanliness and flossing and hygiene.
I'm sorry, say that again?
There's bad things that happen from leaving them in, so why would you even, if they're easy to take out at a young age, why wait?
So the question was, you know, there are lots of things that can go on with the wisdom teeth. They're way in the back there. They're harder to keep clean. They're harder to floss. Harder to get to every crevice and brush around it. Potentially accumulates more bacteria through plaque. And therefore they're more susceptible to infectious diseases, whether it's periodontal disease or caries lesions. So why not take it out early? They're easier to take out early. Nerve regeneration, we know, is better when it's done early. And those are the arguments to be made for their early extraction. My only question would be, that's prophylactic surgery. So you have to make the choice. Do you put the child under and take out the 4 wisdom teeth prophylactically or not? That's a choice each clinician has to make. Should we also take out the appendix then, at the same time? No, that's a joke. But my point is, you have to think about when you want to get into a burden of care and whether you can justify it or not. And that's up to each clinician, up to each patient. Routinely, when I'm taking out bicuspids for orthodontic treatment, if they have wisdom teeth, and if the child is going to be put under, I actually give them that option. I tell them that, you know, if you are going under anyway, then I would rather be on the side of aggressive. And I will talk to them about potentially taking out wisdom teeth if they so choose. Because I would rather not have them go under at the age of 12 to get 4 teeth out, and then at the age of 17 again to get 4 wisdom teeth out. But I'm a little cautious in prophylactic surgery. I'm not a huge fan of it, but that's a personal bias. If you talk to, and I think I told you about wisdom teeth, if you talk to 5 different clinicians, you'll get 5 different opinions. And there's no right and wrong in that. It's, I think, almost a philosophical decision. What I do know is that the wisdom teeth erupting do not tend to cause crowding. That is something that has been reported in the literature in the past, and I think we have to be careful buying into that and advocating the removal of wisdom teeth for that reason. But the other arguments that you brought up are all valid arguments. Go ahead, you had a question?
Let me answer it.
Okay. Any other questions about that? Okay. Well, in summary, I think it's just important that you keep thinking of the basics of this, and that is that the mandible does get displaced downward. The growth of it, or the remodeling of the mandible, essentially takes place posterior superiorly. Think of the regions that we talked about. Think of what happens at the level of the condyle. Think of what happens to the coronoid process, the ramus itself, its adaptive capacity, the corpus, and how the corpus actually helps hold or support the alveolar segment, which is a major part in the vertical development of the lower third of the face. Whether it's the maxillary alveolar segments or the mandibular alveolar segments, that's really what establishes in many ways the vertical height of each of our faces. Bicondylar width, I think I mentioned how that the width of the mandible typically doesn't get changed a whole lot over time. at the level of the condyles because they are fairly well established earlier on by the width of the basic cranium. And the chin does have areas of apposition and resorption. Any questions about any of this?
What was the last one?
Can you go back to the last?
I'm sorry?
What was that last point?
You can go to the last.
The chin has areas superiorly which are more resorptive in nature, but you have areas of deposition. Any questions, comments? Okay, I guess we have one more session together, and that'll be next week, so see you guys then. Thank you.